Hello, hello. I'm Jack Easton. This is BIO461, and we are learning about the heart for the next couple videos. The cardiac muscle, the only one. So to get started, the heart has many different kinds of components. There's action potentials that are triggered in the heart, in the ventricular muscles. And so maybe I can show you on my whiteboard to get started. We're going to be talking about the SA node and the AV node, where they are on the heart, how the heart is oriented. So I'm going to show you this little heart right here at the bottom of my whiteboard right now. This is the right side of the heart, like as if you're yourself, and the right side of the heart. And then this is the left side of the heart. And the heart has two ventricles, labeled them two V's, the left and the right ventricle. And then they have atria above them, left and the right atria. And then this is like your aorta that goes to the rest of the body. You have your pulmonary veins and arteries. You have the arteries that come off of the atria. You have your vena cava here that goes down. The SA node, here, let me tilt this. Okay. Let me draw this out real quick. The SA node is going to be up here in the heart. That's where that is. And the AV node is going to be kind of in the middle right there of the heart. So this is SA, and then this is AV node. So just to get started, that's kind of how we orient the heart itself. And so first of all, we are going to talk a lot about the action potentials in the cardiac ventricular muscle and the SA node that happen. The first part, we're going to talk a little bit about cardiac ventricular muscle action potential. This cardiac ventricular muscle is the contractile cell. It's the muscle that actually produces force of the heart. Kind of an overview. The ventricular muscle action potential has 5 phases, 0 through 4, and lasts about 200 to 300 or so milliseconds. So it's pretty fast, but much longer than skeletal muscle. The long duration of it basically prevents tetanus and allows proper filling between beats of the heart. We're going to start off with phase 4. The heart's a little bit different. We learned about action potentials before, how the cell's resting membrane potential is negative 70 or so. But the heart's resting membrane potential is negative 90 millivolts. And so phase 4 is the resting membrane potential. And then main channels, there's one called the IK1, which stands for inward rectifier potassium channel. That opens, and sodium and calcium channels close. This is when the cell is stable during this resting membrane potential. It's basically maintained mostly by potassium going in to the cell and the sodium potassium pump. Now, to continue, there's phase 0 here that we can see. This is when the cell depolarizes, spreading from the SA node through gap junctions. Gap junctions are the space between each of the cell. And so the channels that happen during phase 0, there's a fast voltage gated sodium channel that opens and it sends sodium into the cell. And then the membrane potential, like we know about sodium, it wants to shoot up all the way to positive 30. These sodium channels quickly inactivate once it hits negative 30, and that's when we get to phase 1. This is the initial repolarization when it comes back. Like I said, the sodium channels inactivate during that phase, and then the ITO channel opens. It stands for the outward potassium channel. It briefly opens and it lets a little bit of potassium in. The membrane, it slightly repolarizes after the peak. That's about all of phase 1. For phase 2, we call it the plateau phase. So this phase here. A bunch of channels are around this phase. These are all potassium channels. This specific plateau phase is unique to cardiac muscle and very, very important for contraction. There are L-type calcium channels that open, lets calcium in. It's slow and long-lasting. There's a potassium efflux and things like that. And then basically the physiological importance of this plateau phase is that the calcium that enters triggers calcium-induced calcium release from the SR, what we learned a few videos ago, which allows contraction. This is all about heart beating and contracting. Next is phase 3 here, as we can see. The calcium channels finally close, and there's potassium efflux. There's still potassium channels. And in the potassium efflux, it basically increases delayed potassium channels, like the IKR and the IKS, these channels here, which are just potassium channels, like I said. And then eventually back to stage 4, where the membrane returns to resting potential at -90. And so hopefully that makes a little bit of sense. Part 2 to this is how the SA node triggers action potentials. The SA node is a little bit different. We can kind of look at the same graph for the SA node. But the SA node is the natural pacemaker that basically sets the heart rate. The SA node sets the heart rate. Unlike this is ventricular muscle. The SA node cells don't really have a stable resting potential like the ventricular muscle does. The SA node has like spontaneous depolarization due to pacemaker currents. Phase 4 is the pacemaker potential. There's no really flat resting potential for SA node. Instead, the membrane slowly just slightly depolarizes. And there's something called CAMP that enters the SA node that basically depolarizes it, which is a little bit different. It doesn't use sodium channels, and so we call it the funny current. And it's activated by hyperpolarization, not depolarization. Usually channels that go up like this are activated by depolarization, but we call this a funny channel because it's activated by hyperpolarization. T-type calcium channels also open near the end of I just lost my train of thought. Also open near the end of this phase, and it causes calcium influx to the cell. This gradual depolarization that calcium causes brings the cells to threshold, which is -40 millivolts or so. And so that's a little bit about the SA node and the action potentials that go into that. Next, we're going to switch gears a little bit and talk about the EKG or ECG tracings. And you've probably seen them. They kind of look like this, but we're going to go deep into it. This is kind of what they look like, but we're going to go deep into the ECG tracings because this comes from the heart completely. And so there are 5. A physiologist once named these different waves the WXYZ waves or something like that. But one of his math friends came up to him and said he needs to change the names of these waves, and so he changed them to the P, Q, R, S, and T waves because X, Y, and Z are used for math. And so we're going to talk a little bit about each of these waves pretty briefly. First of all, we're going to draw each one of these out. Let me draw these out. Give me 1 second. So we're just going to take it 2 at a time because my whiteboard is smaller today. So the P wave we can draw this out. And the Q wave. These are the two that we were going to talk about. Okay. So during a ECG tracing, this is the P wave and this is the Q wave. That's kind of what they look like. Now, when we draw out the heart, we drew the atrias, which are above the ventricles, the left and the right one. And so when the P wave is happening, when we're tracing a person's ECG, like heart rate and things like that, the atria depolarizes from the SA node. And so for this one, let me draw this out. Let's see if we can see it. Okay. Here is the SA node, that little box. Here's the atria. And so for the P wave, from the SA node, the atria becomes depolarized, but not the ventricle. So that triggers a P wave, which is normal. Then the Q wave is there's a superior septum. I forgot to mention this when we drew out the heart. There's a septum, which is another word for wall, between the two ventricles. The superior septum is this area, like the top of the septum. This area is now depolarized from the AV node, like we drew earlier. The AV node is kind of in the middle there. This is all depolarized from the AV node, and that triggers a Q wave. I'm going to erase this, and now we're going to go to R and S wave. Give me 1 second. R wave and S wave. Let's see if I can draw this out good. There we go. It's not too bad. And the S wave. Okay. Here we are. So this is the R wave where it shoots up. As we can see, here's our P and our Q wave. And then this is the S wave. Here's our P, Q, R, S goes down. Right back down. R wave is the depolarization of ventricles. So let me draw out the heart again. Ooh, backwards this time. So here's our heart. Here's our atrias. Here's our septum. Here's our ventricles, the V-looking things. And the R wave is depolarization of, like, mainly this left ventricle and maybe the bottom of the right. Okay. Now, for the S wave, as it goes down, it's now depolarizing, for the R wave, it's almost most of both of the ventricles. For the S wave, as it's going down, we're going to draw the heart out again. Okay. I hope this heart makes sense. Now, all these atrias and the ventricles are depolarized except for the left upper ventricular wall, which is the left side. So this is the left side, because if you're facing a person, it's their left side, not your left. And so most of the ventricles are already depolarized at this point, except for this little part. It still needs to move up. And so this part gets depolarized by the S wave. Now, for the final wave, let me draw this out. This is the T wave. Sometimes this T wave can be a little confusing for people. They don't really know the purpose of it. Okay, do this quick. We're going to draw out a different color just because. T wave. We get to use the whole whiteboard for this one. P, Q, R, S, T. Okay. Oh, I didn't leave space to draw a heart. We'll draw it up here. Okay. Okay, here is our drawing. We have the P wave, which is atrial depolarization, which is this. We have the Q wave, which is superior septum depolarization from the AV node, which is that middle part, the wall. The R wave, which is depolarization of the ventricles. The S wave, which is depolarization of the left ventricular wall, the upper left ventricular wall. And then the T wave is not depolarization. It's repolarization of everything. So when something is depolarized, it always needs to repolarize to get back to normal, or like the part in between your heartbeats. And so as everything in the heart is depolarized, this T wave repolarizes it from the bottom all the way to the top through electrical signals and things like that. Because everything is like a magnet. It's all positives and negatives. And so that's what the T wave does, and then it's a constant cycle. So now we get to talk about, this is the normal ECG tracing. We're going to talk about something called NSTEMI and STEMI, which stand for an ST elevation and depression, which is really bad. Having an NSTEMI tracing in your ECG tracing, when the doctors see that, that probably means you're about to have a heart attack. And this is happening in the ventricles because the S and T, or the space between S and T, are like the final part of the ventricles, not really relating very much to the atrials. Most of this stuff is anatomy, these words. So we're going to talk mostly about the left ventricle. And so, let's see here. Where should I start? So NSTEMI is like a heart attack. They're blood clots. NSTEMI and STEMI are like blood clots that get caught in your ventricles, which are really bad. And these things trigger heart attacks and aneurysms in the heart. And so let me see here. Maybe I can draw this out. I have another drawing that I did right before this that maybe I could copy down to be easy. So yeah, let's draw a ventricle. This is just the left ventricle. So would you agree this maybe looks like a left ventricle to you? And so as these things are getting depolarized and repolarized, an NSTEMI is like a little blood clot right here. And as it's trying to get depolarized, there's a bunch of positives out here that are depolarizing, but this blood clot is all negative. I hope you can see that okay. This blood clot is going to cause an NSTEMI, which is like spelled this way. NSTEMI. The ST stand for just the ST in the ECG tracing. And so this is going to, when it's trying to repolarize, it's going to cause an error in between the S and the T wave in the ECG tracing. And so the ECG tracing is probably going to look a lot like this during NSTEMI. So maybe we can draw an ECG strip here. Okay. So it's going to start, it's going to create a new baseline, which will be kind of the new P wave almost. Well, start the new ECG tracing because there's the blood clot. and then it'll trigger our Q wave normally. Most things will be normal until we get to the S wave and then the T wave. This is going to be how our ECG tracing looks. This is our P wave, this is our Q wave, this is our R wave, S wave, T wave. There's going to be a big gap between the S and the T wave because of the blood clot. And so, and it's just stuck to the inside of the ventricular wall because there's going to be blood flow going, and this blood clot is going to kind of stop that a little bit. If you don't get this caught in time, you should probably go see a cardiovascular surgeon so that you don't have a heart attack, so that they can get rid of that blood clot safely. So that's a little bit about NSTEMI. STEMI is also not good. I don't think I need to erase much except for the ECG tracing. Now we're going to talk about STEMI. Let me draw this out. We're still going to talk about the left ventricle. Let's see. This is also a blood clot, but it doesn't just stick to the inner ventricular wall. It's a lot of the ventricular wall. And so it completely blocks repolarization and depolarization of the ventricles. This will really screw you up if you don't get it caught soon enough. Usually, NSTEMI can turn into STEMI when the blood clot gets too big. So this is what our ventricle looks like if we're having NSTEMI in our ECG tracing. The clot covers the whole ventricular part of the wall. There's like no pathway between these positives. And so this is STEMI. This is really bad. This will cause an aneurysm. And so usually if a doctor sees NSTEMI, you can take a drug to prevent it, but almost most of the time you're referred to a cardiologist to get the NSTEMI fixed so that the blood clot doesn't get bigger and you have a heart aneurysm and die. So the ECG tracing is going to look like this. I'm going to use purple for STEMI. Okay, so you're going to have a new baseline, but the baseline is going to be deeper than before. You're going to have your regular T wave, you're going to have your Q wave, your R wave, and you'll get to your S wave, and this is where it all messes up. Okay, let me label these. Q, R, S, and T. So with every ECG tracing, this is probably what I forgot to mention. After the T wave, your ECG tracing is trying to get to the baseline so that they can start another P wave. This was the original baseline, where it should normally be. This is the new baseline with the blood clot. Then your ECG tracing is trying to happen, and then after the T wave, this is the end baseline, I guess, where it's trying to get back to either one of these, but is kind of confused on which one to go to. And so the S wave doesn't go down past the R wave anymore, and it's very short. This causes an aneurysm. And this is what happens when the NSTEMI blood clot gets too big. And like I said, remember, NSTEMI is just like half of STEMI. Whew. So there we go. Hopefully that makes a little bit of sense. That was NSTEMI and STEMI. Kind of if we mess up the ECG tracing and kind of what could go wrong. Next, we are going to talk about two major neurotransmitters that we've already mentioned a lot about previously. There's norepinephrine and acetylcholine. They control the heart. Now we're going to break these neurotransmitters into three types of effects. Three types of effects are called inotropic, chronotropic, and lusitropic. Inotropic changes the contractile strength, like how strong the heart contracts. Chronotropic changes the heart rate itself, and or it changes in heart rate depending on what the heart rate is. And then lusotropic changes in relaxation rate, so the space between heartbeats. Now we'll look at how calcium plays a big role in all three of these processes. First, we're going to talk about chronotropic effects. It changes with heart rate. We'll start with norepinephrine. Norepinephrine is released from sympathetic nerve endings onto beta-1 adrenergic receptors in the SA node. This will activate a G protein which increases CAMP, and then CAMP directly increases the activity of funny channels like we were talking about before with ventricular muscles. This will also increase the activity of calcium channels in the heart. As a result of all of this, the slope of the pacemaker potentials increases, meaning the membrane, which means the membrane reaches the threshold faster, or a faster heart rate. So all in all, norepinephrine speeds up the pacemaker by increasing the slope of depolarization, while acetylcholine slows it down by flattening that slope and making the cells more negative to start with. Next, we'll talk about inotropic effects, or it changes with contracting. And this will be shifting to like the ventricular muscle instead of the SA node. It's with norepinephrine again. It binds to beta-1 adrenergic receptors, activates G proteins, increases CAMP, and then activates protein kinase, or that PKA receptor that we drew out in one of the last videos with all those boxes. More intercellular calcium basically equals a stronger contraction of the heart, which is a positive inotropic effect. For acetylcholine, it mostly acts on the atrias, not really the ventricles. It reduces CAMP and decreases calcium influx, giving a negative inotropic effect, because more calcium equals positive inotropy. So basically, in short, norepinephrine makes the heart squeeze harder, and acetylcholine softens that contraction so that we can beat normally. Then finally, lusotropic effects, or the relaxation rate. Lusotropy refers to how quickly the heart relaxes, basically. This speeds up relaxation, which is crucial because a faster heart needs to fill quickly, with like depolarization and repolarization, what we were drawing earlier. I guess you could think of it kind of like this. Norepinephrine doesn't just make the heart beat harder, it also helps it relax faster so that it's ready for the next beat. And this is all super quick. This is happening to us constantly. This video might be a little longer, by the way. We still have a little bit. Now, calcium's role in all of this. It's kind of the common thread. Here's where you can kind of zoom in on a cardiac muscle cell and explain the calcium cycle. Excitation begins, depolarization opens calcium channels on the sarcolemma and T-tubules that go deep into the muscles. This small, like, entering of calcium triggers calcium release from the SR through the RYR receptors that we drew before. Calcium binds to troponin C because troponin C is attracted to calcium, causing cross-bridge cycling and contraction. To finally be able to relax, calcium is removed from the cytosol by circa pumps on the outside of the SR, and then back into the SR. So basically, calcium enters, triggers more calcium release, activates contraction, and then has to be pumped back out or stored again to allow relaxation of heart. So in the end, the sympathetic system makes the heart beat faster, harder, and recover quicker, while the parasympathetic system does the opposite, slowing and calming the heart. Okay, we only have one more big thing to cover today, and that is the cardiac cycle. This is awesome. So I'm going to draw this out a little bit and we can get started with it. So first of all, we are going to draw a y-axis, and this is going to be in pressure in millimeters of mercury. I'm pretty sure that's what it stands for. mmHg. This might take me a minute to draw out, so give me a second. We're going to give it some labels. Okay, so let's see. And this is all going to be inside of the left ventricle, if that would make more sense. So, let me see. Where do I start with this one? I'm going to use a bunch of different colors for this, actually, so that it's easier to see. Let me draw this out first, and then I'll show you how it's going to look. Okay, that's enough of that one, and we will go green. Oh, never mind, hold on. Sorry, this might take me a minute. It's kind of a big graph. Okay. We're going to use a bunch of different colors so that's easier to see. Okay. I'm going to call this one So this is all the pressure within the heart. We're going to cover atrial pressure, ventricular pressure, and kind of how they all tie together. We're going to draw one more actually. Something called aortic pressure, which is the aorta, comes from the aorta, and how it moves, pumps blood to the rest of the body. Okay, here we go. So this is what this looks like. It's a little complicated, but here we go. So we're just going to break it down. So there's pressure, and then the orange is atrial pressure of the heart. The green is ventricular pressure of the heart. And I kind of hope you can imagine what the atria look like and what the ventricles look like. And then up here, I forgot to label it, but it's aorta pressure. The aorta is red, like actually. So I'm drawing a red because it's an artery, big artery. Goes away from the heart, pumps blood away from the heart. And so a lot of these lines kind of cross each other a little bit, so we're going to break it into little pieces. So the first cross head is right here, as we can see. We're going to use another color. This is probably going to be the more colorful thing that we do. This part right here, as this crosses, this is the pressure gradient. And so it basically closes the bicuspid valve, because once there's so much pressure behind the bicuspid valve, it's going to, when I'm talking about pressure, I'm talking about blood flow and how much blood there is and how much pressure there is because of the blood. And so the bicuspid valve, or the mitral valve, is going to close really quick in the heart. And we call this the pressure gradient. I just hope you can see it. Pressure gradient. And so we're going to circle this so that we can see it. Okay, that's the first crosshairs. And so the next one, it shoots up once there's so much pressure. It shoots up pretty high to a lot of pressure because we're measuring in pressure. And then up here is the next cross point between the aorta pressure and the ventricular pressure. And we call this point, well, we don't really have a name for it, but it just lets out blood. It just releases a little bit of pressure. Now, this is not an action potential. This is just the process of how blood is flowing and where it's going and how much pressure there is in the heart. The next big part of this is, we call it the dicrotic notch. And it's up here. This dicrotic notch makes a noise. We call it the S2 or the dub noise. And it shuts the semilunar valve. So there's the bicuspid valve, the tricuspid valve, and then there's the semilunar valves. There's two. And this makes a dub noise. So it makes like a dub noise. Oh, I forgot to mention something. During the bicuspid valve closing, this also makes a noise. This is the lub noise. It makes like a lub sound. That's legit what it's called. So there's the lub and then the dub noise. This is the S1 and the S2. Those are like the physiological names for that. And so the dicrotic notch shuts the semilunar valve because of how much blood pressure there is in the heart. And then as this goes up, there's blood that enters. Blood enters up there. And then eventually blood pressure relaxes at an 80. And so the aortic pressure starts at 120 and then relaxes at 80. And you might have seen these numbers before. They're when you're getting your blood pressure checked. Again, I'm going to say it again. Blood pressure checked from the heart. The normal range is 120 over 80. You've probably seen those numbers before, hopefully. 120 is systolic and the 80 is diastolic. If there's too low of a diastolic pressure number, that means there might be bleeding in the heart somewhere. And so to go over this all in all, orange is atrial pressure, green is ventricular pressure, red is aorta pressure. When green and orange cross hairs, the bicuspid valve closes because of how much blood pressure there is. The blood pressure shoots up to like 120 and the bicuspid valve closes, causing a lub noise. When the aorta pressure and the ventricular pressure, or the green and red, cross each other, that lets out a little bit of blood to kind of calm it down a little bit and creates a dicrotic notch, which closes the semilunar valve, which causes a dub noise in the heart. It lets out a little bit, or blood enters, and then finally relaxes at an 80, which is, like I said, diastolic, which is normal. This is normal. A big dicrotic notch is not normal. A small one like this is fairly normal. And then the graph just goes on and on like this. And so I kind of repeated it twice. But we call this the cardiac cycle, and this is in the left ventricle. We haven't learned about the right ventricle and what happens if it's any different, but this is kind of what all of this means when it comes to blood pressure in the left ventricle. So this is all that we have learned within the first week of the cardiac region in BIO461. Thanks for listening.